I'm going to go ahead and introduce myself. My name's Nora Stern. I come from Providence. I'm a physical therapist and I do pain education full-time now. What we're going to be talking about right now is about persistent pain. We just heard about the opiate crisis, and it sounds to patients when we start to talk about restricting opiates that we're taking away their treatment. But in reality, that was never an appropriate treatment for persistent pain, as the research shows, right? The good news is that when you flip our understanding of pain on its head and look at it in a more accurate way based on the contemporary information from neuroscience, it makes a lot of sense as to why medication is not the first thing to think about and why much more active approaches to care are appropriate things to think about. So we're going to be looking at why behavioral health, getting people moving again, and simply understanding pain are the appropriate first lines of treatment intervention. And that's good news, because when your patients start to understand that, they can start to appreciate more of what their options are rather than just simply thinking that they're having something taken away. So that's the basis for the work that we've been doing at Providence around developing pain education for clinicians and pain education for patients. So we've developed a toolkit, and some of you folks were in the learning collaborative that happened over the last few months. I know you were, and anybody else? But many of your colleagues were in a learning collaborative around pain and addiction that happened and have the toolkit that I'll be referring to. And if it sparks your interest, you have the option of your clinic getting a clinic contract for the toolkit, and I'm happy to share information with you about that. But we embarked upon a pretty extensive training for primary care around patient pain education, because research is showing that when people understand pain, it really changes the story. So we're going to look at that as soon as there we go. So to kind of set the stage for how we might think about pain in a different way, I want to give the example of, and this is a little bit graphic, I'm sorry, but I think for Lainey especially with the trauma history, it's relevant. The difference in the pain experience of people who experience perineal trauma from childbirth versus sexual assault. With childbirth, there's profound injury often, lots and lots of pain, worst pain I ever had. Those women do not go on to develop persistent pain, right? A woman who experiences sexual trauma experiences significant pain, significant injury, tissue damage, and a large majority of those women go on to experience complex persistent pain that lasts for years. The context and meaning is completely different. In the case of childbirth, you're anticipating it, you're anticipating the pain, you know it's going to happen, it's normalized, and you're looking forward to the outcome. You may not be looking forward to the childbirth, but you're looking forward to the outcome in most cases, right? In the case of trauma, it triggers an event that potentially destroys your life. And so why does that happen? Our old model doesn't explain it. Our old model associates pain with tissue damage. And that came from René Descartes 400 years ago. So this model shows a person with their foot in the flame, and a pain messenger, a pain signal, is being sent up through pain fibers up to a pain center in the brain. And so the implication of this is that the body is telling the brain that there's pain. And so therefore, your pain experience would be directly related to the extent to which you have tissue damage. That this person with severe degeneration in their neck is going to have severe pain. And if a person doesn't have that amount of something that can be explained from an x-ray, from a finding, from tissue injury, they can't have real pain. And so that left us in a state of sort of confusion. And it left our patients in a state of crisis, going from clinician to clinician, trying to find an answer that they couldn't find because maybe the x-ray was negative, or they had multiple surgeries because they had a finding and it didn't resolve their pain. And at each point in that kind of broken spoke model is an opportunity for more opiates and more opiates and more opiates and more imaging and expensive, very expensive healthcare process, if they could afford it and they could get sent to those places. If they couldn't afford it and they couldn't get sent to those places, then they would show up at the emergency department every 2 months saying, I don't know what to do. My pain is out of control. How familiar does this sound to you? Raise your hand if you've seen a lot of this. Yeah, everybody, yeah. And I think, you know, it's not just in the domain of the Medicaid patient that this crisis has been going on. There's a whole bunch of seats here. I know it's a little squeezed over there to get in, but I want to make sure you guys are comfortable. You know, it's among the insured and the less insured, but the people who, you know, live with a lot of psychosocial complexity are particularly vulnerable to this, and we're going to look at why that is. There are specific reasons for that. So that's left this feeling of being kind of helpless, and in fact, even just the term chronic pain, I think, leads to a sense of helplessness. And I, and many of us who work with pain in the pain education world, have chosen to use the term persistent pain. And the reason for that, it's the same thing. Technically, the diagnosis is still chronic pain, but chronic implies a condition that won't go away and that you're going to have to live with forever, and the best you can do is cope with it. But it turns out that pain, complex persistent pain, is largely a result of a disorder of the nervous system, and the nervous system, it turns out, is very capable of change. It's called neuroplasticity. We hear about it all the time now, right? So it's totally turned this all on its head, and to me, persistent is a much more hopeful and more accurate way to describe a condition that is distressing, that is problematic, but that is not necessarily a fixed state. It's not that I'm saying that it would be helpful to tell somebody who says that they have 15 out of 10 pain for the last 20 years that their pain will go away. But, or, you know, I don't think that's helpful. As Lydia had pointed out, or I'm sorry, as Cassandra had pointed out, we'd given the message to people that they should expect to be pain-free, and I don't think that's helpful. Life is painful, right? But giving people the idea that the best they can do is cope with a static condition is not accurate, and it's not helpful. The new model looks at pain as a process. This is from the work of Louis Gifford, and it's actually quite a few years old, but it really started this revolution. So what it says is that pain is a result of input, processing, and output. And this, to me, is a very elegant model and way of describing what happens. There may be input, especially with acute pain. There may be a lot of nociceptive input from the tissues. But there is always processing at the level of the nervous system in the brain that determines how threatening that information is. And based on the threat value of that information, assigns a pain response, the output of a pain response, and the output of mobilizing the autonomic nervous system and the endocrine system, et cetera, to do the things that the system needs to do to shift gears and protect, because pain is designed to protect us. What it is, where the information is coming from and what it's telling us to protect us from is not always clear. We're wired to, and our culture is kind of geared to think that it's telling us to protect ourselves from something harmful that happened in our body. But in the case of persistent pain, this part may have very little to do with what's going on. And this part may have a lot to do with what's going on. Not to say that there may not still be something happening. For example, with Lainey, she probably, you know, she does have moderate degeneration in her lumbar spine, as shown on X-ray. But approximately 50% of people with moderate to severe degeneration on X-rays have no pain. So the X-ray itself doesn't actually explain her pain experience or anything close to that. And that's actually good news for people who live with pain when they understand it. So pain is what's called an emergent process rather than a linear process. It's a result of multiple factors. It's more like a flock of birds choosing to change direction, or an orchestra. Many different parts of the orchestra contribute to the whole pain experience. And actually, I think an orchestra is the best metaphor, because with complex pain, there's more and more members of the orchestra involved. When you have acute pain, it's a little bit simpler. We'll look at that. There's fewer brain functions involved. It's a bit more of a straightforward process. But the more that your system has gotten used to creating that protective response, the more parts of your brain have become recruited and harnessed or enslaved in the pain response. So an orchestra is a really good metaphor, and actually a great one to use with your patients. When you first got injured, it was a 4-string quartet. And now it's a big band, right? It might be a little bit like a transit map. So the pain response is based on the threat value that your system assigns. And I think that this is helpful because it also helps us appreciate that people who have been struggling with persistent pain aren't stubborn or stupid or difficult, but rather their system has figured out the best way it can under the circumstances to protect itself from what it perceives as threats. And so our job is to be the best detectives with them to figure out what those underlying issues are that have been causing the problems. With me so far, does this make sense? Okay. So pain education, it turns out, itself is a treatment intervention. Understanding pain helps people understand why you might say something like, you know, doing some relaxation training could really help your pain experience. Are you crazy? Why would I relax? You don't understand, I'm in pain. When people understand how pain works, the idea that working on physiological quieting would actually be helpful in calming their sympathetic nervous system and decreasing the fight or flight response. We wouldn't use those words, but starts to make a lot more sense, right? The idea of getting moving. If they start to understand a little bit more about how the sensory cortex changes and can make Laney's pain spread across the low back and up into the thoracic spine, they can start to understand why that would be a reasonable thing to do, and understanding that pain and harm are not the same thing can help a person slowly return to activity. Whereas without that understanding, I want you to get back to moving. Well, I tried walking 30 minutes and I was down for 2 weeks, and you're crazy, you're my enemy, I'm going to get another doctor who will give me opiates, right? So that's the difference. So pain education decreases rating of pain, decreases re-injury, decreases pain catastrophizing, which we'll talk about a little bit, decreases utilization of services, and improves function and mobility. So I want to talk a little bit about some of the changes that happen in the nervous system. The first one is sensitization at the level of the neuron. So this is a picture of one neuron communicating to another. And what happens here is that there's gates that open up and allow chemicals to stream through, okay? When you have a normal, healthy neuron, say this is a nociceptor, danger messenger. So we're going to call them danger messengers rather than pain messengers, because it's not pain until it gets to here, right? From here up, it's just, hey, there's something going on down here you might want to pay attention to, okay? So this is a danger messenger. And that messenger should not be activated unless the system is under significant threat. So light pressure, like hand resting on leg, should not activate this one. And it would normally stay quiet. A few little chemicals would float into the end bulb and it wouldn't be activated. But in the case of threat, there's a whole bunch of chemicals that flood through and the nerve fires an action potential, right? When you have persistent pain, new gates get laid down. They're called NMDA receptors, and they are laid down with the gates stuck open. So they're like this, and a whole bunch of them proliferate all around the end bulb. So what you have then is this very permeable nerve that's constantly taking in information and sending information up to the brain. So a person who has this kind of nerve sensitivity, increased sensitization, can have sensitivity to cold, pressure, chemical changes. It's one of the things that might explain things like fibromyalgia, when people have a lot of cold sensitivity that is not threatening, non-harmful stimuli experienced as painful. This is one of the things that can be going on. But what's exciting is that, so your system says, under threat, lay down an NMDA receptor so we can get lots of this information up to the brain, okay? As the system starts to become healthier, those gates have a half-life of only a few days. So if the system continues to perceive threat, it will continue to lay down those receptors. If the system perceives less threat, then as they die off, they won't get replaced in as great a number. Okay? So as this person slowly returns to health and resilience, this sensitivity at the neuron level begins to improve. So that's one change that happens in the nervous system. Another, and all the things I'm going to talk about are changes that are reversible, which is great news. And we teach this in a pain education class throughout Oregon, and I think it would be great for CareOregon to contract for these classes. And I have some flyers at the front there if you're interested in picking them up. This is the kind of thing we teach in the pain education class. We go through all of this in different language. They're not contracted right now, right? So it would be a pay kind of thing. But people are referred directly into it by Rehab, directly into it by primary care. If they come into our Rehab, if they are referred into our Rehab, they can then go into the pain education class as part of the Rehab program, actually. And then it's free if they come through Providence Rehab. So with the new benefit, or you can send somebody into our Rehab program. And I have some flyers up there. So, so sensory cortical changes are another thing that happens. This is an image of a sensory cortex. So it's the map in the brain that tells you that's my wrist, that's my elbow, that's my knee, etc., right? And when I learned about this, I learned that it was static. But it turns out that it constantly changes. As you learn a new skill, that area of the body becomes more well-defined, and as you stop using a part of the body, it becomes less well-defined. It's use-dependent, which is why the hand, the lips are more well-defined, because those are parts of the body that give and get a lot of important information. And the parts that don't give and get as much important information, like the knee, have less representation. But if I start to play the violin, my left fingers will become more well represented than my right, and my right wrist will become more well represented than my left. Okay? It changes fairly quickly. Research has indicated a pretty rapid response. For example, research that was done on Braille readers found that the index finger representation was more defined during the week than on the weekend when they didn't use Braille as much, which is pretty rapid. Another one that I think is a really beautiful depiction is a monkey's digits were tied together or sewn together and had to go through tasks like this. And in reading the research, it sounds like it was over a couple of weeks, but when the MRI was repeated, the representation had gone from 2 digits to 1 digit during that time of practice. Okay? So think for a moment now about your patient who's been avoiding moving a part of their body, bracing and guarding. Think about Lainey. My back pain has spread across the lumbar spine and up into the thoracic area. It's hard to tell where it is sometimes, but it feels like it's getting worse, and I need an MRI because something bad is going on. Now, this is a study of low back pain that looks at how people perceived, A, where their back was in space, and B, their ability to discriminate 2 points from 1 point, which is probably an illustration of sensory cortical change. The blobs are their back pain, and their 2-point discrimination was disrupted in exactly those places, as was their ability to feel where their body was in space. Pretty amazing. So remembering, though, that this changes pretty quickly, helping people feel comfortable that pain and harm are not the same thing, and that slowly getting back to moving is not going to harm you, like Lainey is afraid of moving, that something bad is going to happen. She's got some catastrophizing going on. And that she has sensory cortical changes happening that can start to reverse as she slowly gets back to moving. Understanding that you being able to talk with her about it can make a huge difference in her buy-in. Oh, you're not crazy. You're not my enemy for telling me to get back to moving. This is actually a treatment, an appropriate treatment intervention for chronic pain. So I want to talk a little bit, too, about disinhibition, how the brain processes can become coupled with the pain response. With acute injury, you have input from the tissues, right? Makes sense. You better have input from the tissues. That mobilizes the sympathetic nervous system appropriately, the fight or flight response. The sensory nervous system identifies the body part. Memory assesses whether this has happened before so that it can accurately evaluate what's going on and what to do about it. Problem solving assesses the situation, and the motor system acts, roughly speaking. So that's kind of a rough depiction of what happens with acute injury. With persistent pain, there's a lot more functions involved. First of all, there may not be very much input going on from the tissues anymore at all. Tissue healing happens in 3 months. So there may be something ongoing like degeneration, but it may have much less to do, or nothing, like fibromyalgia, maybe nothing to do with what's going on with input from the tissues. Premotor planning is now involved. Every time I bend over, my back hurts. So guess what? When you think about bending over, the brain already starts to run that representation for the pain response. And you may have pain or be set up for pain just thinking about bending over. And people will say that. All it takes is for me to think about moving that part of my body and it hurts. The centrality of pain in one's life from attention. Actually, OHSU developed a centrality of pain scale that talks about this, the idea that pain becomes more and more of a central focus in a person's life. In the limbic system, fear and fear avoidance, the association between pain and harm, avoiding moving because you believe that that's not a healthy thing for you to do because it hurts, and the belief that pain and harm are the same thing. Balance and visual input might be involved, like when I shift my weight over the front of my feet because I'm about to bend over, that becomes associated with, harnessed in, enslaved in producing the pain response, such that even that shift might start to run that representation. And this has been replicated in functional MRIs as well. Visual input, the input of the peripheral visual input in the environment you're in, the context of being in the workplace, for example. And then that gets layered with depression, anxiety, and trauma. All of those are very strongly associated with persistent pain. Very much activates the limbic system and the suffering that's part of the pain experience. Pain and suffering can't be separated. They're part of the same definition in the International Association for the Study of Pain, for good reason. They're not separate, ever. It's just that in acute pain, it's a lot more tissue input. In persistent pain, there's a lot more neuroplastic changes and a lot more suffering. So understanding pain starts to change that and starts to help the person kind of emerge again and become a little bit more resilient and less clouded by that whole morass. Problem solving starts to look at how the problems might be different problems than the person had originally thought. Quieting the stress response can quiet a lot of those associations with memories of how much they've been suffering, with depression and anxiety, with expectations about pain. And understanding fear avoidance can help with return to activity, which changes sensory cortical smudging as well. I just read a story in the New York Times today about research that's being done using psilocybin and psychedelia to help people with depression in cancer. And I think that's very much connected to what we're talking about here. The association of the suffering with all those other experiences becomes decoupled, and they're able to attach other associations to some of those experiences that they're having. Same thing with pain and trauma. It's all very connected, yeah. So the last thing I want to touch on is imbalance of arousal. So when you have a threat or a trauma, it mobilizes the sympathetic nervous system, and that upregulates us for survival and downregulates us for maintenance, right? You don't do a rebuilding project when the house is burning down. And that's all normal. So sleep, digestion, reproduction, sex drive, immune functions become suppressed. And the things that we need to do to survive immediately are biased, right, appropriately. So when we get to safety, we go back to a sense of homeostasis, back to a balance of those different functions. But our people who live with persistent pain often, and especially if they have a trauma history, and this is where I think people in a lower socioeconomic demographic who've had a lot of hardships, I don't need to tell you this, have been living with a lot more sense of ongoing threat, you know, and a lot less understanding of what to do about it for a long time. So there's that homeostatic bias towards, the lack of homeostatic regulation has been biased towards survival for a long, long time. So when things are in balance, there's going to be a regulation between that activated fight or flight state and the rest and digest state over the course of the day. You know, when you eat, rest and digest kicks in. When you get stuck in traffic or you get excited, or I'm presenting to you right now, I'm much more, my sympathetic system is much more activated. Then when you go take a walk or you walk your dog, et cetera, you go back down into more of a rest and digest mode. And that's a healthy regulation that allows you then to let your system down-regulate and get to sleep at the end of the day. Persistent pain patients often look more like that. They're all in that kind of, when's the shoe going to drop again? What bad thing is going to happen again, right? And if you think about it in terms of that sense of dysregulation, it puts the context of sleep, for example, in place, and which is a huge issue for people with pain. People with pain don't sleep well. There's many, many things that affects. It affects their immune system, their endocrine system, right? It creates more pain. Simply helping them understand how that fight or flight response can become turned on for too long, and then helping them think about doing, maybe focusing on some relaxation techniques, that being a very valid, important thing to do, can help their sleep and help their pain. And it can help their pain for a lot of reasons. It can help their pain by helping shift their focus, and it can help their pain by helping to create more regulation and homeostasis over the course of the day, so that they're not living in that all the time. So a couple of manifestations of this. One of them is the phenomenon of pain catastrophizing. And you remember that Lainey said that her condition was terrible. She thought it was going to get a lot worse. That's a classic catastrophizing statement. My condition is terrible and it's never going to get any better. Nobody has pain like mine. My pain is 15 out of 10, right? So pain catastrophizing is an irrational negative forecasting of future events in relationship to pain. And, you know, probably if we gave Lainey a test on anxiety, she'd probably score fairly high. I don't think we had that on her case study. This is an example of where behavioral health is a really helpful introduction. If somebody is a higher catastrophizer, and you send them right to rehab because getting moving is healthy. Remember that she's moved to a walker. She moved herself to a walker because she believed that her pain was harming her and she should avoid moving around very much because of that. She's a great candidate for rehab, but she'd be an even better candidate to maybe talk with your behavioral health person at your clinic first and start to understand a little bit more about some of her catastrophic thinking, and then go to rehab. Because the chances are, and actually go into the pain education class in rehab, chances are that without a little bit of that extra help, a person who is a higher catastrophizer might get frustrated at the first difficulty. This is one more thing, you know, rehab will often make people more painful. And if they believe that pain is harming them and that that's catastrophic, then that's going to be a barrier. And it turns out that actually pain education, I had said in the previous information about research that pain catastrophizing decreases with pain education. It decreases with pain education for people who are moderate catastrophizers. People who are very high catastrophizers, it doesn't help. Sometimes it might even give them more things to be afraid of. So I would say for the most part, it probably just doesn't have the effect that we want. So in general, I wouldn't worry about it being harmful, but rather that it needs to be in the context of a really integrated process. And in the absence of a multidisciplinary pain clinic, You use your behaviorist, have them talk with the person about the difference between pain and harm, and then go into rehab in that sequence. Ideally with your behavioral health person having gone through some pain education training. If anybody here is thinking, I really want to be creating a more integrated process, there is the possibility of doing trainings with the pain toolkit for your whole clinic so that the behaviorist and the nurse and the doctor are all using the same language and the same tools. That's different from fear avoidance. Fear avoidance is the belief that pain and harm are the same thing. It's a little bit more like a misconception, a thought virus. Much easier to help people with. And sometimes people have just this. When people are dealing with fear avoidance and they understand pain differently and then they get coached slowly back to activity, it's like a miracle cure. They can have a total transformation of their life. So and there actually are some ways that you can actually test for that if you want to with a fear avoidance behavior questionnaire and a pain catastrophizing questionnaire. They're not the same thing. But I think that because fear avoidance behavior is kind of the low-hanging fruit, it's very helpful to, for example, the pain education videos that some of your colleagues who did the collaborative have in your clinic and that you could get through the toolkit. Is a very easy way to disseminate that information. And that's what we've done is we've actually loaded the videos in each of the treatment rooms so patients can watch it in the treatment room in their clinic. So key points. Pain is a multidimensional experience. Many different pieces contribute to that, not simply tissue injury, right? That's basic. So that means all pain is real. You know, we used to, back before we understood all this, we use terms like malingering, psychosomatic, right? That's not really relevant anymore. That's not an appropriate way to think about, that's kind of a dismissive way to think about pain. If we realize that there's always input processing and output all the time, and sometimes there's more of one and sometimes there's more of another, all pain is real pain, right? But nociception is neither necessary nor sufficient for pain. You can have no input from the tissues and a very robust processing of the pain response, like with phantom limb pain, for example, where there's actually no tissue there anymore, but very profound pain. Pretty amazing. So pain and harm are not the same thing. You can have pain without harm, and you can have harm without pain. So phantom limb pain is one example of how you can have pain without tissue damage, but there's lots of them. I don't know if you can think of any that you've experienced or that came to your mind. Pain without tissue damage. Any thoughts? Yeah?
Well, particularly I have a patient that I'm dealing with right now that has chronic migraines,
Mm-hmm.
and she's gone through the whole workup for everything, and they have no cause for, they've tried everything.
Mm-hmm.
If you have any, experience with migraine pain?
Migraine is pretty complicated. Certainly if it's induced by stress, then some of this sensitization work could be relevant. I think there are probably some other things going on that are more complexly physiologic that I don't think this model completely explains, but it certainly isn't a result of tissue damage going on, right? And any headache, in fact, would be the case. Yeah. Tension headaches, however, very much can fit this model, right? Yeah. Any others that you can think of? Examples? Complex regional pain syndrome is totally output driven. Exactly. Yeah. They might have had a small injury a long time ago, but right, very small usually. And it's very real, right? In fact, you can see things happening at the tissue level, but it doesn't. What's happening with redness and sweating, et cetera, doesn't have a tissue origin now. It's probably got more to do with an autonomic function. Yeah, it actually is central and then output. Yeah, exactly. And in fact, understanding that has completely changed the way we work with CRPS. In rehab, we now do mirror box therapy. We work with the brain. And are very successful, whereas we used to do things like hot and cold baths, which were completely ineffective because there wasn't a tissue origin to the problem.
You're giving ketamine injections.
Right. Yeah.
What's mirror box therapy?
Mirror box therapy is like the Wild West of rehab. It's so cool. It's actually called graded motor imagery, and it uses so mirror neurons exist throughout the brain, and they're neurons that help one part of the brain help us teach what's happening on the left side to the right side, but also help us learn when we're babies about what another person is experiencing. When they exist in the midbrain, they're called empathy neurons. So if you watch somebody have that horrible injury on a sports, and you feel something, that's a mirror neuron phenomenon. So the graded motor imagery goes through a series of first helping the person recognize left and right. So say, for example, they have CRPS in the arm. And if they were to draw their body, they might draw a black space, not even pain throughout the arm. They might actually not be able to perceive that that part of the body is there. They're that cognitively disconnected, sensory cortically disconnected. Okay? So the first thing that we do is recognition of left and right. That's a left, that's a right. We're looking for accuracy and speed. And sometimes people will have an increase in symptoms with that. They'll actually even have, if they have CRPS, they'll even have an increase in swelling. That means we've moved too quickly and we need to kind of back up maybe to just watching people's hands, and then we would move up to laterality recognition. They practice that every day. Then we go to imagined movement, where they're imagining maybe putting on gloves or using buttons, and all the sensory associations that go along with that. If you think about the ways that the brain has harnessed all of those different functions to be coupled with the pain response, we're decoupling that from the motor activity, and so that they can begin to associate activating those parts of the brain with a pleasurable activity or a non-threatening activity. And then we go to the mirror. So if it's a right hand, they've got the hand inside the box. They're looking at the illusion on the left side. Do the same thing with phantom limb pain, but you can also do it with osteoarthritis of the knee, anything really, stroke. And you would take off rings so that there's an accurate illusion, and then you watch that illusion moving smoothly and easily. So you're bypassing the premotor cortex, and you're getting those brain responses to be decoupled from the threat of preparing for movement. It's total, and then they slowly start to, you can do touch and slowly begin to have that involved limb moving as well. And so they can handle desensitization touch treatment earlier. Sometimes you might do the desensitization on the uninvolved side first, so they see that it's safe, and then move to movement and move to tasks, and it's totally cool. And House did it one time. It was so awesome. I was at a course with my hero, Lorimer Mosley, who was one of the people who really developed graded motor imagery. I was in Vegas at a course, and he had just talked about all this stuff, and then I was at my hotel, and I was the only episode of House I've ever watched, and he put himself through graded motor imagery. I was like, wow, it's like God speaking. So, and then you can have harm without pain, like in a battlefield injury, for example, where people might have had lost their hand, totally traumatic injury, and they're not even aware of it. Or in car accidents, people who work in the emergency department, and you can't believe that they haven't processed this traumatic injury that they've experienced. It's because to put it in kind of more general terms, the threat value of everything else going on around them overrode the profound injury that they experienced. Their system couldn't afford to assign priority to that threat because there was something much more threatening happening around them, right? When they get to safety, they would feel very real pain. And that's exactly what people who work in emergency departments say, right? When the patient starts to feel safe, and there's reasons, there's chemical reasons for that, right? Their endocrine system starts to kind of calm down. They stop having that incredible flood of norepinephrine. There's a lot of ways that we make that happen, but that's part of the whole experience, how relative pain is. So we create threat a lot of the time when we talk about our MRI and X-ray results as being terrible and debilitating. When we inadvertently tell people, oh, if that hurts, don't do it. the struggles that people have living with pain, that adds to the threat. And then the message that people have gotten that medication is the only thing that can help them, which is where understanding pain totally changes the threat, because they can see now that there's actually so many things that can help you so much more than opiate pain medication, or even any medication. Anything that is a passive intervention it's not that it's never appropriate, but it should not be the first line. You want to make sure that people are doing everything that they can to change, to activate themselves and get themselves to in a more resilient place before you think about something like an injection or medication, et cetera. So we can be conveying more messages of safety and hope with understanding pain, with how we respond to an X-ray finding. Yeah, I see that you have moderate degeneration in your lumbar spine, Lainey, and that may be contributing some, but there's a lot of things that happen that contribute to the pain experience. And actually 50% of people who have moderate degeneration like yours don't have pain. So I'm not saying that that's not part of the puzzle, but it's not, you're way more complex than that. And we need to together understand your pain story so we can together develop your specific plan of care, because the X-ray doesn't explain it. You have way more of a story than that. And that's something that people appreciate, is they want to tell their story, but being able to help direct the storytelling to the things that help them shine a light on what's made their pain perpetuate, I think is the thing that we need to do, and motivational interviewing skills can help with that a lot. So the idea of thinking about being sore but safe as you slowly return to activity, and if we have a little time later, I'll take you through an exercise that helps you think about how to coach people to return to activity. And then the idea of bringing pleasure back into your life, right? How many people have you worked with pain who've said, well, I used to do X, Y, and Z, but I don't do that now because I'm painful. Right? I used to have these hobbies. I used to spend more time with my grandkids, but I can't do that right now because I'm painful. And what happens then is that the centrality of pain becomes greater and greater, and pain becomes their primary relationship. And one of the ways that I find most effective to drive this point home to people is to say, have you ever had the experience, and we do this in the class, every time I teach a class to patients, I say, have you ever had the experience, anyone in the room had this experience, of doing something really engrossing, like you're with old friends, or you're playing with your grandkids, or you're playing with your puppy, or you're doing a hobby, and you realize you didn't have pain during that time? Anybody had that experience? And almost everybody nods their head. Well, that's really common, and there's a reason for that. It's not just that you were distracted. Yes, you were probably distracted, but it's actually more complicated than that. Actually, your system wasn't really processing pain during that time because it wasn't assigning importance to it. So your system wasn't perceiving a threat at that time, and you were not having pain. So the clue there is that the more you can bring pleasure back into your life, the less priority pain can have, the less control it can have, the less dominant it can be. It's like if you've got a ski slope full of snow, you've been running that sled down that one rut. The rut gets deeper and deeper and faster. That's what happens with the pain response. But you can go down other parts of the slope as well. And if you do, then that one rut starts to fill in with snow a little bit. That's kind of what we want to do together. And then quieting stress. So in terms of getting back to moving, I talked a little bit about the role of behavioral health. Rehab can be really helpful in helping people get back to moving. Not all rehab does what I'm talking about. The department that I come from, we have actually trained all of our therapists in this model. So that message about pain versus harm is going to be something that you're going to be pretty confident your patient is going to hear. And we have specialists who do deeper work with graded motor imagery, with physiological quieting, et cetera. It's important that all of our professions start to give the right messages because we don't want to see you guys giving good messages and then they go to the emergency department and they get told, oh, there's nothing you can do, you're going to have pain forever. Good luck to you, get out of here, or whatever. So this is one of the places that you can be confident if you send your patient, they should be getting this kind of information. And then the pain education class I had mentioned as well. I just bring it to your attention. Right now I don't know that it's necessarily a resource for your patients, but just so that you know that it's there and maybe we can work out a partnership. So I just want to show you a little bit about our toolkit that, as I say, a lot of your colleagues have. And so this is one of the videos that we have. In the problem-solving parts of our brains, the brain can make the pain greater when we're confused about why we're still having pain. But pain can decrease as we make sense out of the pain and understand why it's happening. The feeling part of the brain can increase pain when we're worried and stressed. But we can decrease our pain as we become less fearful of pain and more hopeful. We sense pain differently when we start to move less. We start to feel pain in bigger parts of our bodies, but as we begin moving again, the sensing part of our brain returns to normal. Avoiding movement increases pain when we expect more and more things to hurt. But as we slowly get back to doing things, this part of the brain also quiets the pain. And then I'll show another section. So this patient was kind of a classic fear avoidance kind of story, and when she got information about how pain works, it really was transformational
Mary,
for her.
the physical therapist that I worked with at Providence, taught me how to accept the pain first. Accept it, embrace it, and then we'll work through it from there. This weeding's good for me because all the roots that have been holding this crud in here for so long is like the pain, you know. My rear end grew roots to that chair in there on that heating pad. And now that I'm out here able to pull these roots, feels like my roots have been pulled up and moving again, so it's a good thing.
I love her. So we also have teaching aids, and this is an example of one. I'm going to grab one here. This is the one that talks about the relative meaning of degenerative change and says basically that half of people with severe degeneration have no symptoms, and 10% of people with a totally normal x-ray have severe pain. And it's got some scripting on the back so that the, and it looks like, we have one on stress and pain. There's that one, yeah. So you have scripting on the back that can kind of cue you for ideas about how to talk with your patient. So this is a great one for talking about the difference between pain and harm. And also just the idea of whether or not you want to go off and get another x-ray, which might show more degeneration, but isn't necessary, and it might show no change. Yeah?
Are those part of the proprietary toolkit, or do you have access to them?
Those are part of the proprietary toolkit, yeah. So if your clinic would like to use this as a whole clinic, then I have information on how to contact me about that. So, and the video as well, yeah. So here's some ideas about scripting. I'm worried about my x-rays. A response that might increase threat. Your x-rays look pretty bad. I've said that. Something that might create more of a sense of safety. Half of people with joint degeneration have no pain. So, you know, there may be some other things going on here. Let's talk about it together. I can't do blank. I can't walk. I have to use a walker because it's too painful. Well, you'd better avoid doing that then. Physical therapists were guilty of that statement horrifically. Or, you know, your system has kind of gotten a little too good at protecting you, but it and produces, as a result, has produced a lot of pain, but that pain actually doesn't mean that you're causing yourself harm at this point. We can feel confident that nothing harmful is occurring. So let's talk about how to slowly introduce activity a little bit at a time, and gradually we'll be able to increase what you can do even if you're having discomfort during that time. So you don't want to tell people only do the things that aren't painful, but rather change the message about what the pain or discomfort means. And maybe using the term discomfort or soreness rather than pain will de-threaten as well. So those are some ideas about how changing the language changes the threat and the message. So actually, since we have a little bit of time, I'd like to maybe just go over an idea about pacing to return to activity, if that's okay with you. All right. I'm going to try and draw and hold a mic at the same time. So Lainey has difficulty walking. She used to be able to walk a whole lot. Maybe she used to hike. And if she kept walking for a really long time, she might have a protective pain response that would tell her, don't keep going, because if you keep going, you will injure yourself, right? Because pain is supposed to be a warning. If she kept going further, she might get tissue damage. But below that, she could do all kinds of things. Take the dog for a walk, go grocery shopping, do the laundry, go to the grandkids' soccer game without pain and without tissue damage. Okay? With persistent pain, the level at which you have tissue damage is going to be a little bit lower because of deconditioning, say, right? But it's going to be maybe down here. Where's the level of the protect by pain response? Way down here, right? So the first thing that's really helpful to realize is the difference between pain and harm. So that even though she's having pain, she's not harming herself. But when she does go to the grocery store, do the laundry, take the dog for a walk, she's having pain during that time. She's nowhere close to hurting herself. But she's having pain. So if she keeps doing all of those things, it's not harming her, but it is continuing to fire that alarm bell of a system that's already too active. So when we coach people back to activity, we might say, well, so you used to be able to climb a mountain, and your doctor told you to start walking, and you walked 30 minutes and you had pain for a week. That would be what we would call a flare-up. Okay? We want to avoid that, not because it's harming you, but because it continues to keep the system more active. Keeps that pain response loud. What about if you walked 15 minutes? What do you think? How do you think your system would respond? I wouldn't be able to do that. I'd be painful for 3 days. What about 10 minutes? No, I can't do that. What about 5 minutes? Well, 5 minutes is nothing. No, 5 minutes is not nothing. It's a really good start. Or for some people, it's just getting up and walking across the room and back at every commercial, because all they're doing is lying in bed and watching television. That's a great start. So you're going to do that depending on how intense the activity. It might be every hour when commercials come, every half hour when commercials come on, or it might be twice a day, go for a walk for 5 minutes. So you're not going to have a flare-up, but you are going to have some discomfort. But you're sore but safe. So you walk 5 minutes twice a day for a week. And she uses her walker, that's fine. Her system starts to become stronger. She doesn't need the walker. Somebody with moderate degeneration in the spine does not need a walker to walk, physically speaking, right? So she builds up her musculature, her sensory cortex becomes healthier, she starts to feel more hopeful. And then the protect by pain response goes up a little bit. She increases to 6 minutes every day for a week, and then 7. She doesn't jump up to 15, and she doesn't get freaked out if she has a flare-up. She learns from it. Did I not sleep well the night before, have a fight with my spouse? Did I actually walk longer than I had expected to? That kind of thing. But you keep going, and you gradually increase the resilience, and you increase the raise the flare-up line, and you raise the level at which you would have tissue damage. Yeah?
You tell people when they say they have pain all the time, they can't really detect a flesh flare. Because I try to teach pacing to my patients in terms of figuring out how long they can go on average without experiencing a flare.
Well, if they have pain all the time and they're not experiencing a flare, then that's great. They're not experiencing a flare-up. In terms of this coaching, they're okay. So they're probably going to limit themselves anyway. And I would say if you're talking about how to help them with return to activity, you wouldn't want to just say, oh, well, then just walk 30 minutes and get out of my office. you would probably want to set a goal that they can be successful at. So I would say maybe I might respond like by saying, you know, so you're having pain all the time. To me, that's a sign that your whole system is very sensitized. But the good news is that it doesn't sound like you're actually having flare-ups, which is great. If you do, if you have a real setback that happens for multiple days, then we need to talk about that. You don't need to freak out. You didn't harm yourself, but we want to talk about it and learn from it.
You're going to discriminate against their normal pain levels on an acute pain flare with them.
Right, right. Yeah. And this isn't acute pain like acute injury, right? It's something else. So I would say, you know, it's possible that you may have a flare-up, but don't worry about it. Just come back and talk with me about it, and we'll learn from it. Probably we just pushed a little too hard, but it's not something we need to be scared about, okay? So what we'll do then is we'll start out at a low level, and I want to see if we can find something that you feel like you can take on, and then we're going to start out real slow. So I might then say, how about if you walked to the end of the block and back twice a day? You know, or, you know, what are you doing normally? What's the longest walk that you normally do? Great, we're going to do that systematically twice a day between now and when I see you again. And then, so that is probably how I would approach that, yeah. So to keep us on time, I think I'm going to pause, right?
Yeah, absolutely. Thank you, Nora. Everybody give Nora a big hand, okay?